Hi, my name is Kristin Elam, and I will be reviewing the case study analysis interpretation of the Framingham study data. First, I want to discuss the description of the study sample. A couple things to say about the study sample, just some background information. By the early 1920s, diseases of the heart consistently ranked as the #1 cause of death in the United States. The Framingham Heart Study was started in 1948 by the newly established National Heart Institute, which is now what we know as the National Heart and Lung and Blood Institute, which is associated with the National Institute of Health. This study was the sample size was selected in the town of Framingham, Massachusetts. This is the first long-term cohort study of its kind, and the Framingham study is kind of like the crown jewel of epidemiological study. This study sought to unravel what were the underlying causes of heart disease. So, as it was started and the sample size was selected in Framingham, Massachusetts, for this longitudinal cohort study, the reason that Framingham, Massachusetts was selected was because the site was just big enough to provide a sufficient number of participants for the study, but it was also small enough that it was well suited for this community approach to recruit and effectively follow the participants over time. Originally, with this study, the sample size was 4,434 participants. With this sample, each participant had between 1 and 3 observations. Observations were done biannually, and the total number of observations totaled to be 11,627. So for this study, you have two data sets. One set consists of only data collected at the first examination for each participant. And then the second data set is the complete data set, which includes all of the observations. Next, I would like to discuss some of the risk factors associated, comparing men and women initially at the start of the study. Okay, so this is our baseline, this is our starting point. Men, there were 1,944 men. Women, there were a little more in the study, and was 2,490 for the total of 4,434. So noted, there are more women in this study than men, slightly. The average age, there's a lot of similarities between men and women. The average age, if you look at the chart, roughly 50 years old, plus or minus, the standard for I just want to make note that on this chart, continuous data is reported using means and standard deviation. Categorical data is reported using counts and percentages. So, as I said, with the age, the standard deviation for the men was 8.72. For the women is 8.64. So, average age is around 50 years old. So that part of the sample was similar. Also, when you look at the other risk factors, including systolic blood pressure, incidence of hypertension, use of antihypertensive medication. Let's just take a look at those three things. As you can see that they're very similar. Um, for example, systolic blood pressure, both categories, they actually, both men and women are running systolically hypertensive at the start of the study. And of course, you see they, out of the study, 74% of men already had a diagnosis of hypertension. 72% of men and 74% of the women already had diagnosis of hypertension. Going down to looking at the use of hypertensive medications. Although these folks are hypertensive at the start of the study, 2% of the men are receiving antihypertensive medications. Only 4% of the women are receiving those medications. So this is setting up our template. There is a difference between current smokers. As you can look at the data here, 60% of men were current smokers, as however, with women, 40% of the women were current smokers. So that is something to make note of. And then, of course, at the end, those that data in reference to strokes is the same for both men and women. 9% had already had strokes. So this is just at our baseline. This is what the comparison between men and women, and just to recap, very similar. The difference is the smoking, right? More men were smoking than women. That is one of the big differences. But everything else is pretty close. Let's talk about characteristics associated with heart rate. So this is we're going to discuss, I want to first discuss the distinction between the crude regression coefficient and the multivariable regression coefficient. Um, the crude regression coefficient is unadjusted, okay? So it represents the relationship between the independent variable and the outcome without accounting for any other potential confounding variables. And confounding, of course, we know means a confounding variable may modify the relationship between the exposure and the outcome. So again, the crude regression coefficient is not accounting for those confounding variables, as opposed to the multivariable regression coefficient, which is adjusted. So it is providing a more accurate estimate of the relationship by adjusting for potential confounders. So I think, so let's go over. So looking at the crude model, as you can see, all of the risk factors, male sex, glucose, total serum cholesterol, current smoking status, and diabetes, all of these risk factors are associated with heart rate, okay, in the crude model. However, when we look at the multivariate model, we see that there is a change, okay? So when it is adjusted, diabetes is no longer statistically significant, a statistically significant factor. As we look at the regression coefficient 0.911, and the p-value is not significant at 0.519, okay? So that is a big difference between the two of them. Also, I want to note a couple of different relationships. Age and male sex have actually a negative relationship with heart rate. So when you look at age, the regression coefficient was 0.033 and the p-value was 0.143. And for male sex, the regression coefficient was negative 2.878 and the p-value was 7.81 exponential to the 14th power, I believe. So just wanted to make note of that. Another thing to discuss is that the regression coefficient for current smokers in the multivariable model versus the regression coefficient in the crude model, there is a distinct increase from 1.459 to 2.192. And this may be due to the addition of the male sex to the adjusted full model. Because if we were, as we remember from the slide before, men had a greater proportion of smoking than the women at 60% and women at 40%. The next slide, I'm going to discuss the interpretation as to why some are likely to have prevalent coronary heart disease or widespread coronary heart disease. With this data, it's based on p-values based on 2 independent sample t-tests. There are statistical differences between the participants with the history of coronary heart disease and participants with no history of coronary heart disease. So those with a p-value less than 0.05, right? Age, systolic blood pressure, diastolic blood pressure, total serum cholesterol, and BMI or body mass index. So all of those had a p-value of less than 0.05 and were statistically significant. Well, what does this mean? Well, it means that participants with a history of hypertension have all the characteristics which we now associate with risk factors of cardiovascular disease. So, which is in line with what we have discovered over the years with the Framingham Heart Study, right? Back in the old days, they did not associate these risk factors with coronary heart disease. And as we look at this data, we can see that yes, they are all significant risk factors for cardiovascular disease. For example, increased age, if you look at that, you can see that the age at 57 that when there's increased age, which makes sense that there is significance in that. As we know, women, when they are menopausal, they're going to have more incidence of coronary heart disease. Also, looking at elevated systolic and diastolic blood pressure. Well, we now know today, when you look at those values, you see them increase. Systolic and diastolic blood pressure increase with a history of coronary heart disease. And when you look at the values, they're way above normal. Normal systolic would be 120/29. Normal diastolic would be 80/84. And so we know with increasing today, we know with increasing those levels, you will have an increase of coronary heart disease. Of course, as the Framingham study showed over time, that elevated serum cholesterol levels, cholesterol over 200, is related to coronary heart disease. And you can see that with those on the chart, with those with the history of coronary heart disease. And lastly, BMI. We have learned over the years that elevated BMI is a risk factor for coronary heart disease. And it shows that it's significant on this chart. The average BMI at with history of coronary heart disease was 26.8. That would be considered overweight, not obese, but we know that obesity is related to coronary heart disease. I just wanted to mention some of the going back to the other slide. Let me just, can't go back. Going back to the other slide, just want to make note of some historical things as I just discussed. In 1961, high blood pressure and high cholesterol were identified as risk factors for coronary heart disease. So that came out of this study. In 1967, the study determined that obesity and lack of physical activity were risk factors for coronary heart disease. And in 1976, age, which stated women after menopause have an increased risk of coronary heart disease. And this is just some data I had pulled from the National Institute of Health describing the study, so I do want to make note of that. Lastly, I'm going to speak about interpretation of the data collection methods used versus best practices. So I did a comparison between how the Framingham Heart Study obtained their data versus best practices, which would be contemporary practices. That's how I interpreted it. So so I'm going to compare the Framingham to what we would do in a contemporary time. So as we know, the Framingham Heart Study was the first longitudinal cohort studied, was a longitudinal cohort study, the benchmark of its time. The strength of it is that you had the long-term observations that you can really see, um, the impact of different risk factors. One of the weaknesses of this type of study is the attrition of participants. Now, in the Framingham, because it was a small community and they had that small approach, I think they were able to mitigate that, but some of it, but of course, you still had some. Also, it can result in attrition bias, which means that there is a systematic difference between those who remain and those who drop out, and sometimes it can lead to skewed results or invalid con- conclusions. Um, so comparing that to what we would do in a contemporary best practice, of course, nowadays in 2024, Framingham, the sample would not be appropriate. It wasn't very diverse at that time. So now, we would certainly want to create a sample size that's more representative of the nation, meaning a more diverse population, which we can extract that is similar to what is, in the United States of America. Um, One of the weaknesses of having a diverse population, um, unlike Framingham, which was kind of isolated, it's very difficult to retain. The retention is also an issue. It can be challenging and it can be expensive. I wanted to make note of a couple of studies that came from Framingham that address more diverse populations. Just want to mention those quickly. In 1987, there was the arteriosclerosis risk community study that was using 15,000 individuals from the US, and they were from 4 communities within the US. So creating a more diverse sample size. Also in 2000, there was the MESA study, which is the multi-ethnic study of atherosclerosis. That sample size was 6,800 individuals from 6 US communities. So again, creating more diversity. So as I stated, contemporary best practice would keep it diverse, but you do have some challenges with that. Um, so going back to the Framingham, the data collection method was regular comprehensive biannual exams, which included, as we know, a physical exam, right? Multiple blood tests, including cholesterol, blood glucose, um, also, they conducted surveys every time in the meeting to get an idea of their lifestyle. Okay. Um, so there was a strength in this because it provided a very rich data set with many variables that, as we see, as I spoke in the previous slides, they're able to extrapolate and to find out that these certain things were risk factors for the development of coronary heart disease. There was a weakness in this because the frequency, them having to come twice a year, may be a little burdensome to some people. And, of course, that reduces retention. In modern data collection in 2024, we have a lot of more technical advances to kind of mitigate some of these things. So in 2024, we have now electronic medical records. We have wearable devices. You can monitor the heart. Um, over time, the person doesn't need to come in, their heart can be monitored. Also, we have different technologies, continuous glucose monitors. We have mobile apps, right? We have watches and different devices. So, I mean, are a lot of different modern technological technological advances that make data collection a little different, a little less cumbersome. So that technology is definitely a strength. Um, Now, weakness in that area would be, of course, when you use these devices and different things, there's an expense with that. Also, infrastructure and computers and different things. And also, data privacy and security is an issue. How do we control how this person's personal data is it getting out to through the internet and whatnot like that. So, um, that is one of the disadvantages of the way that we would do modern, or I'm considering modern best practices. Lastly, want to look at how the data was collected in the Framingham. Um, Data collected in the Framingham, because of the time, this was in the 40s. So everything was manual, right? Everything was manual and it was entered in manual. Of course, the study provided robust data, but anytime you deal with the manual process, you have human error, right? And of course, at this time, 1948, you have technological limitations. With modern or best practices, data analytic techniques, now we have a lot of technology that can help with dealing with big data sets. Um, we have machine learning, we have big data analytics. We have programs that can handle complex data sets and maybe even uncover patterns and associations that may have been missed, um, when you're doing things manually. So that is something to consider. So, and so this concludes my presentation, um, discussing the interpretation and analysis of the data obtained in this exercise. Thank you very much.